If the last 5 diseases that we've discussed so far are causing you to be a bit confused, don't be surprised. They definitely sound similar, and they have some overlapping features. Hopefully, what we're going to do here is give you some pertinent lab values that will help you wean down a differential that you've been developing as you've read through a clinical scenario. First off, 2 of these diseases have no abnormalities at all. These are osteoporosis and osteopetrosis. Similarly, Paget's disease has only one lab abnormality, and that is an increased alk-Phos. Remember, these are not diseases that are caused by an inappropriate hormonal regulation of minerals. They are simply inherited or acquired defects in bone architecture. The final 2 diseases, however, are actually defects in bone mineral metabolism. In osteomalacia and rickets, patients have a deficiency of vitamin D, which causes them to have low levels of calcium. This triggers an increase in PTH levels to bring calcium levels up, but in doing so, also drops phosphate levels. Osteitis fibrosa cystica is the name of the bone disease that accompanies hyperparathyroidism. Here, you would expect that your initial lab value, the PTH, would be elevated because that is the basis of the disease. This in turn causes an inappropriate increase in the levels of calcium, and also a loss of phosphate. Additionally, we will see an increase in the alk-Phos. In patients with polyostotic fibrous dysplasia, the main pathology is that bone is actually replaced with fibroblasts, collagen, and some irregular bony trabeculations. As the name implies, it is an abnormal fibrous growth of many bones in the body. There is a type of polyostotic fibrous dysplasia that may be very boards relevant, and it's called McCune-Albright syndrome. As in any syndrome, there are a constellation of symptoms you expect to find in these patients. As we already discussed, the first is polyostotic fibrous dysplasia, but notably, it will be multiple bones only on one side of the body. Often patients will have skin lesions on that same affected side, which are known as either café au lait spots or Costa-Main spots. The final component of this syndrome is an endocrine abnormality, and the classic one you'll hear about is precocious puberty. It's truly a remarkable presentation. Alright, we're going to discuss primary bone tumors now, which is not an incredibly high-yield topic. Let's turn our attention first on the benign primary bone tumors. There are 2 that you should know about. Giant cell tumors are the first high-yield tumor in this group. They occur in the epiphyseal end of long bones. They mostly occur at 20 to 40 years of age, which is one of its distinguishing characteristics, as most other tumors tend to be in a younger population. They are locally aggressive and often occur in the distal femur. Classically, X-rays will show the double bubble or soap bubble appearance, and histologically, they'll show spindle-shaped cells with multinucleated giant cells. One more classic fact to know about giant cell tumors are that they are more likely to present in females. The next tumor we'll discuss is slightly lower yield, but has a couple characteristics that should make it easy to recognize if you are asked about it on step 1. Osteochondroma, which from its name indicates it is composed of both bone and cartilage, is in fact the most common benign bone tumor and is often seen as a piece of mature bone with a cartilage cap in younger males. It commonly happens in the metaphysis of bones. It grows out of the bone and presents as an exostosis. This type of tumor can malignantly transform into a chondrosarcoma, though this is fairly rare. And now we'll move on to the malignant tumors of bone. There are a few that you'll be expected to know. There are technically 4 different malignant neoplasms, but only 3 of them will be discussed here. The 4th one, multiple myeloma, is actually the most common and will be discussed in the Heme-Onc lectures. The second most common malignant bone tumor is osteosarcoma, also known as osteogenic sarcoma. It most commonly occurs again in the young age group of males, aged 10 to 20. Like the osteochondromas, osteosarcomas are also found in the metaphysis of long bones. All of these details that we just mentioned may help confirm your diagnosis, but the reason you should think about osteosarcomas in the first place is because of these 2 ideas. A, what they look like on X-ray, and B, predisposing factors for osteosarcoma. Classically on X-ray, osteosarcomas are described as appearing as Codman's triangle or as a sunburst pattern. These terms radiographically describe what is happening pathologically in the bone. The tumor cells are growing underneath the periosteum of the bone so fast that the periosteum is being lifted off its normal plane of growth, which creates the triangle or sunburst that so classically describes osteosarcoma. The second thing you should remember for this high-yield tumor is the predisposing factors for the cancer. The list is long, but worth remembering, and includes Paget's disease, bone infarcts, radiation, and familial retinoblastoma. With the first 3, you can imagine reasons for bone to be damaged, and more prone to dysplastic changes as a result. The second malignant tumor to know is Ewing's sarcoma. This is a type of tumor that's called a small blue cell tumor, a family of tumors that includes neuroblastoma, medulloblastoma, retinoblastoma, and Wilms tumor. Like all other tumors in this family, Ewing sarcoma is very aggressive and presents often with early metastasis. However, it will respond well to chemotherapy, which is life-saving for patients. It can happen in a variety of bones, usually in the diaphysis of long bones, but also in the pelvis, scapula, or the ribs. There are two classic aspects of this disease to remember. The first is that it has an onion skin appearance in the bone. You can remember this with the memory aid, Ewing's and onion rings. Kind of rhymes. And the other important thing to remember is that it occurs as a result of an 11 to 22 chromosome translocation. There aren't any other malignancies on this page with similar translocation, but in the Hem/Onc chapter, you'll see at least 3 more, so be sure to keep this straight. If you follow basketball, 11 plus 22 equals 33, which was Patrick Ewing's number. The final tumor you should remember is the chondrosarcoma. We discussed this a moment ago, as it can result from a benign osteochondroma, but at times it can also occur as a primary tumor. It occurs in older men, as the transition from benign to malignant often takes a long time in bone. It can occur in a wide variety of bones, usually avoiding the distal extremities and skull. The classic appearance you'll hear this tumor described as having is that of an expansile, glistening mass from within the medullary cavity. Osteoarthritis is a very common disease. On the Step 1 exam, common diseases will show up in questions very often. Sometimes they'll give you a presentation that will make you think of another disease, but will not give you that single additional classic feature that gives you a more exotic diagnosis than OA. Remember, common diseases present uncommonly frequently, while uncommon diseases present commonly infrequently. Always remember to consider the simple, easy, common diagnosis first, and only go with something more exotic if in fact you're given a detail that truly confirms it. Osteoarthritis is a disease that is thought to be mechanical in etiology, with chronic wear and tear of joints that leads to destruction of articular cartilage. It is often marked by nodules in the DIP and PIP joints, called Heberden's and Bouchard's nodes respectively. It is almost exclusively found in older individuals, especially those who are obese, which puts more mechanical stress on the joints. Prior history of joint deformity also predisposes, for example, multiple prior joint injuries. Usually, patients will present with osteoarthritis with pain in the weight-bearing joint after repeated use, particularly at the end of the day, which improves with rest. When it's in the knee, it's usually in the medial aspect of the knee. There are a couple of aspects of this disease that make it more classic. For one, this is a non-inflammatory arthritis. When we speak more about the different inflammatory arthritides, this will be more clear. Because there is no chronic inflammatory undertone to this disease, there are no other systemic symptoms that come along with it. This is very different from chronic inflammatory arthritic diseases like rheumatoid arthritis. If you look at the image provided at the bottom of the fact, you'll see a number of classic patterns of simple osteoarthritis that will appear both pathologically and radiographically. On the left side, you'll see the basic anatomy. There's a large joint capsule that travels up the side of the joint as well. Within that, there is a synovium which provides further protection for the joint. Finally, there's a piece of articular cartilage on each side of the joint overlying both bones. The radiographic features of osteoarthritis might be worth committing to memory, not just for Step 1, but for the wards as well. In osteoarthritis, this normal anatomy can be markedly affected. For one, the capsule can thicken and the synovium will hypertrophy. The joint space itself will narrow, with ulcerations developing in the articular cartilage surfaces. This can also lead to bone touching bone directly, leading to sclerosis and bone cyst formation. Finally, osteophytes may form, which can protrude into the joint space, or out around the joint space borders. With all of these pathological changes occurring in the joint space, it is not hard to believe that patients with osteoarthritis can experience significant pain from their disease, which may even require joint replacement. In contrast to a non-inflammatory disease like osteoarthritis, rheumatoid arthritis is the first of a few inflammatory arthritides that we'll discuss. Rheumatoid arthritis is thought to be an autoimmune arthritis affecting synovial joints with formation of a pannus in the joint. Pannus basically just means an overhanging flap of tissue, and it is mostly used to describe this in rheumatoid arthritis. Clinically, as with many autoimmune diseases, females are much more likely to present with rheumatoid arthritis than men, often younger females. Also, as with most autoimmune diseases, it is important to know some of the key immunologic properties that distinguish this disease from other autoimmune diseases. For one, it is marked by type 3 hypersensitivity. The classic antibody is aptly called rheumatoid factor, or RF, which is actually an antibody that develops against IgG, another antibody. However, only 80% of the people with this disease actually are positive for rheumatoid factor, so while it is important to know, it is not necessary to make the diagnosis. There is another antibody called anti-CCP antibody, or cyclic citrullonated products. These CCP molecules are thought to be involved in the inflammation that happens in the joints of people with rheumatoid arthritis. While the anti-CCP antibody is less common, thereby making it a less sensitive indicator, it is also more specific, meaning if it is positive, you are much more likely to truly have rheumatoid arthritis. Also, there is a segment of the HLA molecule, ER4, that is associated with rheumatoid arthritis. Classically, patients with rheumatoid arthritis present with morning stiffness greater than 30 minutes that improves slowly with use. Patients with osteoarthritis will have morning stiffness as well, a result of not moving all night while asleep. This often resolves in less than 30 minutes. Also, the disease tends to be symmetric, so if certain joints in the hand are affected, then the same joints on the opposite hand tend to be affected as well. Most importantly, though, you'll see systemic symptoms in patients with rheumatoid arthritis, a very important clinical indicator to help make that diagnosis. Systemic signs will include fevers and fatigue, but can also be more subtle, with pleuritic chest pain representing underlying pleuritis, or vague chest pain indicating underlying pericarditis. Use these differences to choose between the two on Step 1 questions. First-line treatment involves the use of NSAIDs to decrease inflammation. Selective COX-2 inhibitors, such as celecoxib, are also frequently used, especially if the patient has a history of GI issues with NSAID use. Glucocorticoids and other drugs which modulate the immune response may also be taken by these patients. Clinically, the physical exam and radiographic findings can be very telling for rheumatoid arthritis. The physical exam may show subcutaneous nodules, which would appear like small bumps, often not incredibly large, but usually multiple are apparent. These rheumatoid nodules don't only have to be in the skin, but can also be in the lungs or other viscera. Exam of the joints themselves should focus on the hands, particularly looking for ulnar deviation and subluxation of finger joints. As you may imagine, chronic inflammation within the fingers will lead to many frank deformities of the joints. Within the fingers themselves, MCP and PIP joints are often involved, but characteristically, the DIP joint is not involved, in contrast to osteoarthritis. You may also notice boutonniere and swan neck deformities of the finger. The boutonniere shows a flexed PIP and an extended DIP joint, while the swan neck shows an extended PIP and flexed DIP joint. The Z-thumb deformity may also appear, which is a hyperextended interphalangeal joint.